Okay, go
Oh,
ahead. Sorry, somebody will not have 2 minutes.
it'll be okay.
Yeah.
I think we covered diabetes pretty
Okay.
good. So we need to teach them how to store the insulin. It's only good for 30 days once they open it. And then we need to teach the sick day rules, which are to report the blood sugar and ketones to the doctor, substitute foods for Jello, cream soups, and crackers because they need equal carbs, encourage liquids like half a Coke, half an orange juice, half a cup of broth, report nausea, vomiting, and diarrhea to the doctor, take their meds even if they're not eating or vomiting, and if they are vomiting, check their ketones every 3 to 4 hours if they're type 1, and weigh themselves, take their temperature and their breathing rate frequently, and don't take any non-prescription medications without talking to the doctor. And she said the best way to prevent DKA is to follow the sick day rules.
And take supplemental doses of insulin. That was a question which I missed it.
Do you remember how, or what, try to think like how you would phrase that? I don't remember it.
I think was a select or not apply.
Okay.
And I think I didn't choose because I thought that you give only a little bit of insulin, but actually supplemental doses. It's not just a little bit, it was a dose actually. And I didn't make the difference between a little or a dose.
Okay, we'll watch for that one.
Yeah.
Let me see what else about that.
On DKA, intracranial pressure, ICP, could be a consequence.
Okay.
When the blood glucose falls too far or too fast before the brain can equilibrate, then water is pulled from the blood to the cerebrospinal fluid and brain, which could cause edema and intracranial pressure.
Okay, perfect, thank you. And then the care of a hospitalized patient with diabetes mellitus, you want to let them do self-care, so have them be involved, do good hygiene, keep their skin clean, dry, use lotion, but not between their toes. They're gonna be more stressed in the hospital, so it's gonna increase their blood glucose. And then she said to think about GERD patients, they're gonna be eating different types of meals in the hospitals than they'd be eating at home. And they're not as active in the hospital. It's a good opportunity to evaluate their knowledge and self-care. And then for the insulins, Tammy had a cute way to remember the rapid, they all end in log. Think of a log rolls fast, so rapid. So the Humalog and the Novolog, that's the Lispro and Aspart. And then she mentioned at the review that Lantus can't mix with anything. That's the long lasting, but it's also used frequently in the hospital.
And the IV is the regular insulin.
Yes, the only insulin you can give IV is regular.
Yeah.
And I think that's it for diabetes. So that was all in module 1 that we just covered.
Okay. Was a question about the neuropathies.
Oh yes, I missed the painless MI question. Oh, it killed me. That was so sad.
Which question was that one?
There was a question about painless myocardial infarction, and
Yes.
that can occur if they have diabetes because they couldn't feel it because they have neuropathy in their heart.
That's it. Okay. Yes, it's a silent MI.
Yes,
Yes,
painless or silent MI.
Correct. Okay.
Yeah, I missed that one. Okay, so upper respiratory disorders. Let's see. I was kind of going over this because my notes were a lot more in depth for the module than they were on the blueprint. So I think we just need to know kind of general for the rhinitis and the sinusitis. She said that the viral rhinitis or sinusitis is the common cold that lasts 1 to 2 weeks. If it's bacterial, then you're going to use antibiotics and it can last up to 12 weeks. The non-pharmacological care is heat or cold compress, moisture, steam, and a nasal lavage. And then we have the trans illumination test where we can shine the light below and their brow will glow red.
Yes.
And that's all I put for those two because I think it's going to be pretty basic.
Okay. There was a question regarding the sinus, the discharge. The discharge can be clear, and you don't need to do any test to test that discharge because it's a sinus. Don't confuse it with the trauma in the nose when you have the clear and is the cerebral fluid leakage. Then you have to do.
I got that wrong.
The test.
Yes.
That you and me, we got
Yes.
it wrong, Sally. Okay.
It's because
Don't
of the
confuse
injury.
them.
Yeah. The
Yes.
injury is the difference between that.
Correct.
Yeah.
Correct. Don't forget about. And she mentioned that the sinus can get in the complication of meningitis.
Yes, I had that on my review notes. She
Yes.
said that any infection of the ears, nose, or throat, then a complication can be meningitis. So think worst case scenario because it's close to the brain.
Correct. Okay. Just.
Yeah.
And she told for us to know the medication for the sinusitis, the antihistamine, the expectorant, the corticosteroids, and I think was one question. Yes, I remember the question was regarding the antihistamines, like the Zyrtec, Claritin, the side effects interaction for the older adults because they have many medications, then they can interact to each other. And that was a question.
Thank you. Okay, then for the epistaxis, the nosebleed, the positions, you're going to keep them upright, head tilted forward, direct pressure for 5 to 10 minutes. You can use a cotton nasal tampon or pack it every 3 to 4 days. And she mentioned this twice. She said, if you see lab work like we did in class for that group thing, if they have low platelets and a nosebleed, you need to watch the low platelets for thrombocytopenia.
Yes.
So I starred that one because she mentioned it a few times.
That's true.
You're also going to watch the airway, vital signs, and pulse ox.
And I think the question was about do not do vigorous exercise after the epistaxis.
I remember that too. Okay. And then for the laryngeal, I don't know how you say that, laryngeal cancer, she said that early signs and symptoms are hoarseness, cough, sore throat, and a burning throat, but she added that one at the test review. I didn't remember burning. And then the late signs and symptoms would be a persistent hoarseness, foul breath, dyspnea, dysphagia, nasal obstruction, and an ulcer. And then you can also have general signs and symptoms because it's cancer. They can also have fatigue, weight loss, and lymphedema.
And I think was a question about the signs, the hoarseness in the test.
I think persistent is the key word there.
Yes,
if it's
that's it. Because you can have the hoarseness for 2 weeks, that is the early sign. And when it's persistent, is the light sign.
The risk factors are going to be if you're older than 65, if you have tobacco or alcohol abuse. The race factor here is if you're white or black. If you're exposed to chemicals, tar, mustard gas, leather, paint, or metals. And then if you have poor nutrition or poor immune system. And then the diagnosis, they can do a laryngoscope, a biopsy, a barium swallow, a CT, or an MRI. The partial laryngectomy, you're going to have a voice quality change, but you'll still have a voice. And they can swallow and their airways intact. A total laryngectomy, they're going to have no voice. They're going to need a trach. They're at risk for aspiration, and they have an airway change.
Yes.
And then for the trach suction safety, we need to know that you're going to use sterile water, a sterile glove on the dominant hand, and you're not going to suction for longer than 10 to 15 seconds. We're going to keep an obturator and a trach tube at the bedside. And we're going to keep the airway pattern with the suctioning. So I remember this was a question. Suctioning is not a planned action. Like, you don't go in and do it every hour or 2 hours. It's when they need it. And I don't remember exactly how she worded it, but it's something like it's not a planned intervention. It's as needed intervention, something like that. And we should suction when secretions are present or when breath sounds are not clear. And it's considered a sterile procedure.
I missed the question on this. So after they suction, they should have less coarse sounds, correct?
Yes.
Okay, because I missed it. For some reason I put, I don't know what I put, but it was wrong. So,
It's
okay.
because suction can only get rid of coarse crackles. It can't get rid of
Okay.
fine crackles.
Okay, that's what it was.
You still have fine crackles.
Okay,
Because the option was no crackles, fine crackles,
yes.
and you should put fine crackles.
Yeah.
Okay, so there still will be fine
There
crackles.
still will
No,
be,
it gets rid of
yes.
the coarse ones.
Yes.
Okay, thank you.
Yeah. And then she emphasized that they cannot take a bath or go in a pool if they have a trach, because they could slip and it can go in the trach.
Yes.
But they can take a shower if they wear the hood over it.
And that was in the exam that they go in the shower and cover it. And you know how you can cover it in the shower? With a beep. It's a
With
beep.
what? Oh, a bib?
Yeah, beep. I didn't know how you cover it. I even searched it because I was curious how you can go in the shower and cover it. I could not imagine. It's a beep which you put it.
That's funny. Maria, it's really cute how you say the word bib.
How do you say it?
Bib.
Bib. Whatever. It's okay.
It's cute. Okay. I think that's all for upper respiratory. So hematology. She said we do not need to know taco or trolley. So that was good. Because she didn't even know what it was when we asked her at the review.
That's true.
Oh, sorry, I have to reposition.
That's true.
Okay, but we do know, she said that we would have a question where she gives us a CBC panel and we need to look at those closely. And she specifically talked about, we need to know the difference between leukopenia, which is low white blood cells, and ANC, the absolute neutrophil count, because she said we can have leukopenia, but not ANC in the same patient. So watch that carefully, because I missed that question because I was looking, oh, okay, white blood cells, neutropenia, but they're different.
Yes. And the absolute neutrophil count, it's connected with the chemo.
Yes.
With the nadir. Huh?
She said chemo and radiation can cause the neutropenia with the ANC because the neutrophils are the first responders.
Yes.
Yeah. That was one I had missed before.
Okay, let me keep going. Was a question in the exam regarding the, let me find where it's clear In the exam was a question about the, let me see, where is it? I don't find it. Was about the neutrophils that nadir, NADIR.
The
that-
nadir.
Yeah,
Yeah.
correct. Okay, after 7-10 days, there will be very low neutrophils, the absolute neutrophil counts, and you should give the filgrams.
Filgrastim.
Yes, that one is the medication for the nadir, for that low count. Everything is low.
Yes.
Okay, and maybe when we get to the chemo, I will find exactly how she worded.
Yeah, I remember that one too. And
Okay.
she did mention filgrastim. So that's
Yes.
the that is the hemopoietic growth factor to increase neutrophils. And it's the abbreviation for filgrastim is GCSF.
Yes.
And then the Neupogen increases white blood cells, and that's GMCSF. And that one is good after fungal infections, but the filgrastim is good after chemo.
And it's for the infection for the virus.
Yes.
No,
And then
bacterial.
bacteria, yeah.
Yes.
And then the erythropoietin or the epigen is only if they're in kidney failure, because the kidneys aren't producing enough red blood cells. And she also mentioned this is where we would also give it to Jehovah's Witnesses. We would give them erythropoietin or epigen to help them if they were losing red blood cells.
Yes.
Okay, so transfusion safety. Never warm the blood, never add meds to the blood products. Check for any previous reactions or allergies. We need 2 nurses to check the ABO group and the RH type against the cross match. They also both need to check the name of the patient, the hospital number, and the unit of blood, and the expiration date. It needs to be given with normal saline in the Y tubing, and we need to begin it within 30 minutes from getting it from the pharmacy with a 4-hour total time. She said that the vital sign checks is kind of by policy right now. So she just said no to stay with them for 15 minutes. Some places say do vital signs every 5 minutes, but she just said you'll stay with them for the first 15 minutes because within that first 15 minutes, they're most likely to have their hemolytic reaction.
Mm-hmm.
So the types of hemolytic reactions, we have the allergic reaction, which is hives, rash, facial flushing, and itching. The febrile reaction is fever, chills, anxiety, headache, tachycardia, tachypnea, and it occurs with patients who have had multiple transfusions.
Mm-hmm.
And then the acute hemolytic reaction, this is the life-threatening, where they're going to have headache, chest pain, the flank pain, chills, fever, tachycardia, and if they have pink urine, they're having an acute kidney injury. And this one usually occurs in the first 15 minutes or the first 50 milliliters of the blood. And she said the answer on the test is going to be stop the infusion. So she said at the testing.
Okay, there was a question about in the exam, and I remember the low back pain, the flank pain, which means that the flank pain goes with acute hemolytic reaction. None of them had that symptom. Okay,
Yeah.
And then we had the question, all those 5 steps: stop the infusion, the IV, keep going, the vital signs, call the doctor first, and then the bank. Okay.
Yes.
Those 5 was a question.
Yep, that was an ordering question.
Yeah.
That question was thrown out because I went and showed her that her test question was out of order compared to her PowerPoint. So I don't know if she'll do it again. So I got it wrong because I followed the PowerPoint, but anyways, we'll see. If she does it again, I'll talk to her again.
Okay.
Okay, for the okay, we covered the alternative blood products.
Yes.
For the anemias, we only have to know the two.
Yes.
So the iron deficiency anemia and pernicious anemia.
Mhm.
Let me get back to those real quick. She said we don't need to know the other anemias, we don't need to know sickle cell, and we don't need to know hemophilia for this one. So the pernicious anemia or B12, they're going to lack intrinsic factors, so they can't absorb the B12.
Mhm.
And this was a test question, and she specified again that this can happen with a gastric bypass surgery because they remove part of the stomach, which puts them at risk for decreased B12 intrinsic factors.
Mhm.
And the other causes of B12 is aging, genetics, a faulty GI absorption, and a strict vegetarian or vegan diet.
Mhm.
Signs and symptoms are going to be a sore, beefy red tongue, the paresthesia, and jaundice. The treatment, you can try to have them eat more B12 foods, but I don't even know why that's an option because they don't have the intrinsic factors, so it's not going to help that much. So they need the cyanocobalamin injection once a month, and they can also use the Colomist nasal spray.
And I think the cyanocobalamin was a question.
Yeah, I think so too. It's a once a month injection.
Yes.
IM.
Correct.
And then just to remember, you're never going to give IV iron.
Yes.
It has to be sub-Q or IM.
The B12.
Yeah. Oh, yeah. Sorry, the B12.
Yeah.
I wrote that down wrong. B12 is never IV.
Yeah.
Okay, then the iron deficiency anemia, you're going to teach them that they have to take the iron with orange juice. And this was on Evolve. Don't take it with milk or dairy. The vitamin C helps the absorption. And so also think don't take antacids for the same reasons as the milk or dairy.
Mhm.
And then I think on Evolve, it also had take it with cranberry juice was an option if you didn't have orange juice. The signs and symptoms are going to be a decreased oxygen carrying. And so you're going to have fatigue, pallor, irritability, decreased perfusion, glossitis, dry skin, and sores in the corner of your mouth. And the diet is going to be the organ meats, spinach, red meats, and dark green leafy vegetables.
The sore red tongue is not the same with the beefy tongue.
No, it's different.
Yes.
So glossitis is different from the sore beefy tongue. It has to say beefy to be pernicious.
Okay.
And then another thing to think about for this one is the treatment for iron deficiency is the oral iron, which is the ferrous sulfate. And if they have kidney disease, it has to be IV ferumoxytol.
Mhm.
It's the FERUMOXYTOL. So we can give it orally unless they have kidney disease, then they need IV.
Mhm.
Okay. I think that's all for those.
Mhm.
Okay, so for oncology, she mentioned again to look at the care plan on page 358 to 370, care of the patient with cancer. And then we talked about for neutropenia, it's going to be less than 1,000, and they can't have any plants or fresh flowers in their room. No raw fruits or vegetables. Signs and symptoms include a fever of 99.5 or higher. They need to call the doctor and start on antibiotics within 1 hour of the 99.5 or higher. And this is what Maria was talking about. 7 to 10 days after chemo is the nadir window. And this is the greatest chance of getting an infection with a high rate of sepsis. And then with the ANC, it's going to be less than 500, which is life-threatening and dangerous. So we're going to give broad spectrum antibiotics. Okay. Then for the patient safety, I don't know. Do you think we need to know the primary and secondary? Do you guys know?
There was a question about the primary
Yeah.
and secondary. Okay, was a question about, let me turn it in there to what was, I don't really remember which one was now, but I know there was one with a primary, the diet or losing weight or exercise, something like that. That was the primary.
Yeah, I think you're right. So primary, just think primary prevent, PEP.
Yes.
So primary are things you're doing actively to prevent it, like low fat diet, vegetables, fruits, sunscreen, hats. And secondary is after you have the disease, but you don't know yet before something's wrong. So you're going to get screened, early diagnosis, mammograms, self-breast exams, tumor markers, things like that.
And I think the vaccine was a question. The vaccine goes in the primary. The HPV vaccine goes in the primary.
Okay. That makes
And
sense.
hepatitis B goes in the primary. I think there was the vaccine because it was not something very common, but was
Yeah.
in the primary, the vaccines.
That would make sense because it's preventative.
Yeah.
Okay. Then we need to really look for the complications of radiation and chemo. I have that here.
One question which was about extravasation.
Oh yeah.
When you give the chemo and you have necrosis of tissue, burning, and blotchy redness, the vesicant, then
Yes.
that is extravasation. That was a question.
Yes. So the vesicant is the chemo, and the vesicant can cause blistering, necrosis, and severe swelling. But if extravasation happens, it means that the vesicant is leaking into the tissue, and then it can cause pain, redness, and fluid leaking. So you're going to stop the IV and apply a cold pack and elevate the site.
Yeah.
And if it's infiltration, then it's a non-vesicant into the tissue is infiltration.
Yeah.
Okay, so for the radiation therapy, you can have the skin reactions. They can vary from slight rash, dry erythema, tenderness, or they can have the moist discrimination. This is Maria. This is your gravy question. So Ms. Shelton mentioned it again. If they get the mouth ulcers,
Yeah, that's it.
they're going to have dry mouth, and so they need gravy on their food. And we need to thicken their liquids so that they can swallow.
Yeah.
And this can happen long term. So it can happen while they're having radiation, or it can be a side effect years later after treatment. They still need gravy.
Yes. And she mentioned gravy out of Blue Moon.
Yeah, she did mention that one again.
Yeah.
And she also mentioned with the radiation that we're going to use mild soap, wear cotton clothes that are non-restrictive. And she gave the example at the review that we would not wear a bra if you had radiation to the breast, because that would be very painful. And she said, Miss Jones said to think about where the radiation is. Let me find where she said. Okay, she said, if you're getting radiation to your head or neck, you're going to have a hard time eating. So think of the esophagitis. But she said radiation to the head or neck does not affect the brain. I guess there's confusion about that. That is totally different. So don't think brain, think mouth, throat, and lungs. And then if you're having radiation to the abdomen, think it's going to affect the GI lining. It's going to be inflamed and you can get diarrhea. If you're having radiation to the bladder, you can get hemorrhagic cystitis or bleeding. So she said, think about where the radiation is, because radiation is local. So think about the issues that would be local, and then do good skin care. And then the dexamethasone is the steroid to decrease edema from the radiation. Okay, the oncology emergencies. She said we do not need to know polycythemia vera, but we do need to know superior vena cava syndrome, which is the compression or obstruction of the superior vena cava. So it's going to be the swelling from here up, and it can also be in the hands. But you're going to have extreme facial edema, neck edema, a feeling of tightness, dysphagia, JVD, increased cranial pressure, which is worse if you lower the head of the bed. I think this was a question. And then the late signs can be visual disturbances, loss of consciousness, headache, altered mental status. So the nursing management, we're going to keep the head of the bed up. Don't take any blood pressure on the upper extremities. And to prevent it, we can use good oxygen, anxiety management, and remove restrictive clothing. And she also mentioned cluster the care for this one. Okay, for the spinal cord compression, for this one, it's all going to be about local inflammation, edema, venous stasis. You're going to have back or neck pain, and it's going to be exacerbated with movement, coughing, sneezing, and the Valsalva maneuver, because it's all about shrinking the tumor is what needs to happen here. So pain control, range of motion, watch the skin break down. She also mentioned the dexamethasone here for the steroids to reduce the edema. The treatment is going to be radiation, surgery, or chemo, all to shrink the tumor. For the hypercalcemia malignancy, this is the increase in serum calcium in patients, and it happens in 20 to 30% of all cancer patients. So the calcium level, she said that we need to know this. If it's hypercalcemia, it's going to be greater than 10.5. And she said she'll make it high, like 11, so that we know.
Okay.
The signs and symptoms are all about calcium. So think hypercalcemia, mental changes. You can have a paralytic ileus. You can have a MI, seizure, coma, so anything cardiac. The treatment is going to be loop diuretics and 3 to 4 liters of fluid per day. And she also said it helps to ambulate to help get rid of the calcium as well.
And I think one of the question was about the diet, if I remember. You don't lower the calcium in the diet, you maintain the diet.
Okay. All right. Okay. So but you maintain it because it's a syndrome. It's not actually because of the diet.
Yes.
And then tumor lysis syndrome. That is when this can happen 3 days prior or 7 days after chemo. And potassium and phosphorus go up and calcium goes down. So you can think of what happens with hyperkalemia and hypocalcemia. So you can have lots of neuro signs and symptoms.
Okay. Audrey, we need to stop and I will enter again, okay? Because it's less than 1 minute.